last but hopefully not least, I'm going to close things out with a relatively straightforward topic relative to what we've heard already tonight, indications and techniques for ankle fusion. I do have one disclosure. I am a paid consultant for Wright Medical, and they do have an ankle fusion system. You know, there has been a major shift in how we approach ankle arthritis. As we have heard from the speakers tonight, and as we are all aware, ankle replacement has really experienced a resurgence over the last 5 to 10 years with significant improvements in both the technique and the implants, and as you heard earlier, even navigation now. And this has, I think, resulted in a greater comfort level with the anterior approach to the ankle, both for ankle replacement and for ankle arthrodesis. And additionally, we're seeing fusions being converted successfully to total ankles in many centers really around the world. And I think all this has led to really a different philosophy for ankle fusions. We're now doing them in a way that will allow easier conversion down the road, particularly in young patients that you think need a fusion now, but maybe a conversion when they are older. And I think all of this has been a major driving force behind the evolution of all the anatomic anterior plating systems for fusions that we have seen on the market. The indications for ankle fusion are very broad. Arthritis of any type, whether it's infectious, post-traumatic, or inflammatory. You can almost tackle any level of deformity, as you can see in this x-ray here. Really, any adult age can be treated with a fusion. The cutoff for fusion versus replacement is debatable, and maybe we can discuss that after my talk. And of course, these are folks that have all failed conservative treatment. And there are very few contraindications to ankle fusion. Peripheral vascular disease is obviously one of them. If there's an active infection, certainly you may want to consider a thin-wire fixer rather than internal fixation. Any patient with limited bone stock or poor bone quality, such as AVN of the talus, may be a better candidate for a TTC rather than an isolated ankle fusion. And patients with triple arthrodesis are probably more functional with a total ankle versus a pan-talar. Here's an example of a patient who has extensive AVN of the talus, and you can see the collapse of the body extending into the neck here. And this patient's probably better served with a TTC arthrodesis versus an ankle fusion, which may not have a very high fusion rate. Here's a patient that had a triple arthrodesis and was in her mid-50s, and we elected an ankle replacement here rather than what I consider fairly non-functional if we converted her to a pan-talar. So just a couple of examples of patients that maybe have at least relative contraindications to ankle fusion. In terms of ankle fusion approaches, there are a number of them. Arthroscopic, we are not going to focus on in this particular discussion tonight. In terms of the open approaches, there's anterior, lateral through the fibula, and posterior, which is certainly the least common. You know, in terms of patient positioning and access, I think anterior is probably the easiest. It's right down the front of the ankle, and they're in the supine position. Usually, particularly in post-traumatic arthritis, unless it was a pilon, previous scars can be avoided. You have very good exposure from medial to lateral. The fibula can be left intact, so it's a less invasive procedure, and there may be some benefit to that if there's consideration for future conversion to a total ankle. And if you consider the anterior distal tibia and the dorsal talus, there's a relatively large bony surface available for plate fixation, and that anterior incision for most implants is the same incision you would use for a takedown later. So certainly a lot of advantage to the anterior approach. Advantages to the lateral approach, you do probably have better front-to-back visualization, and it is well suited for patients that have lateral-sided problems such as a retained fibular plate, fibular malunion, hardware discomfort, where you need to address something on the lateral side. It is very powerful for deformity correction, in my opinion, even easier to correct severe deformities laterally than it is even anteriorly. And because you have access to the fibula, it can be used as either a biologic strut or it can be morselized for graft. And here's an example of a patient with post-traumatic ankle arthritis. You can see the tail is subluxated laterally. These arrows are sort of in the wrong place, but this fibular plate is long and prominent, and there's a non-union here where the green arrow is. So if this was a patient you were going to treat with an ankle fusion, certainly a transfibular approach may be better than anterior, so you can address the lateral problems. Now, the disadvantages, positioning is a little bit more challenging. They have to sort of bump up the hip or put them lateral. It does require fibular osteotomy if there's not already a non-union there, which if you like to repair the fibula or add some level of complexity to the case. There's less bone for plate fixation if you choose that over just screw fixation because you have a relatively small area of talus laterally. And for most of the total ankle implants on the market, this would not necessarily be the same incision you use for a conversion later. Posterior is by far the least common approach. In my practice, I use this more often for revision and salvage. TTC arthrodesis, don't use it often for a simple tibiotalar fusion. Its main advantage, in my opinion, is that the soft tissue planes are often very clean. So if a patient has a lot of scarring or previous approaches that have been anterior or medial or lateral, this is usually a pretty clean place to approach the ankle. Obviously, the patient's placed prone and the posterior tibial nerve is at some risk. Technically, it is harder to correct the deformity from posteriorly, and it's harder to visualize the joint, but nevertheless, it still works well in select cases. Fixation options really fall into two categories. You can use cross-cannulated screws, 6.5 or 7.3, there are different sizes on the market, or plate fixation with a lag screw. And we can sort of talk about both. This is a 43-year-old with post-traumatic arthritis, fairly straightforward, not much deformity, that I treated with cross screw fixation alone, and here she is 1 year post-op with a solid fusion, and she did well. And I think screw fixation does work well in many patients. However, there are problems. It's a less stable construct if you compare it to a plate fixation. There's limited surface area for cross screws, so you sometimes run into traffic with each other, and this can present a technical challenge. If the bone quality or patient compliance is unpredictable, then the screw fixation is often unpredictable. And here's an example of a 60-year-old that went on to a non-union after a transfibular approach with two crossed screws. These were, although they're fully threaded, they were placed in lag fashion. And we revised this with an anterolateral ankle fusion plate. So certainly plate fixation has a role in revision surgery, but I think we're starting to see it being used also in primary cases. And that has been the evolution of my practice. I prefer an anterior or anterolateral plate with a lag screw. I think this provides a very stable construct. The fixation is reliable, and you can get excellent compression. And with the new anatomic models available, it's relatively simple to apply. So if I'm going to use the anterior approach, which, as I mentioned, is which is what I do for the majority of cases, I make an incision just lateral to the tibial crest, and we dissect down to the anterior tibial tendon and dissect right through the floor of the anterior tibial tendon, as you would for a total ankle exposure. Full thickness flaps to expose the ankle joint, and I like to use a distractor with K-wires like the Hinterman device, which I usually place on the lateral side of the ankle, which also helps retract the soft tissue, and you can get a nice visualization of the ankle with relatively little damage to the bone, and it's sort of a hands-free way of getting a good exposure. The fibula is left intact. In fact, I even leave the lateral gutter alone at this point, and I will autograft most cases with proximal tibia, certainly the ones that are high risk. After the joint is prepared, and it's a typical curettes and osteotomes, I usually fenestrate the subchondral bone with a small drill bit. We will position the ankle plantigrade and provisionally secure this with a couple K-wires. And the first fixation that I use is the so-called home run screw, which is posterolateral from the tibia into the intermedial aspect of the talus. And this can certainly be a hassle to put in. You know, the leg has to be held up while the surgeon places the screw from back to front. Make a stab incision just lateral to the Achilles tendon, and then dissect bluntly down to the posterior tibia and place the guide pin. And I typically will use a partially threaded cannulated screw with a washer. Initially was not using a washer, but just felt in some cases that screw was moving into the metaphysis, and the washer prevents that. There are a lot of different plates on the market. With the anterior approach, obviously you're going to use an anterior plate or an anterolateral plate. I do like the anterolateral plate in that it sits submuscular, and I think causes a lot fewer problems. Causes fewer problems with hardware prominence and pain. We usually will secure the plate to the talus first with a non-locking screw, and then add a non-locking screw on the tibial side, typically in the compression slot if the design that you use has one. And then I'll fill the remainder of the screws holes with either locking or non-locking screws, depending on the bone quality. And here is an example. Here's an 85-year-old female who had post-traumatic ankle arthritis and had hardware removed a number of years prior. And we placed the home run screw first, and this is before I was using a washer, and you can see how it did sink a bit into the metaphysis, and then the anterior compression plate. And if you look at the biomechanical data, it's pretty impressive. The home run screw adds almost 20 times stability to the construct of the anterior plate. So in my opinion, the home run screw posterior to anterior with the anterior plate does facilitate a much stronger construct. Here is a 67-year-old male who had post-traumatic arthritis with a similar treatment. In this case, we did use a washer. And you can see the anterior plate. This is an anterolateral plate, which sits, as I mentioned, in a more submuscular position, and I think is much more soft tissue friendly. Lastly, just a comment on lateral plate fixation. This is less commonly used, but does work well when lateral exposure is necessary. And here's a case of that. This is morbidly obese. She was in her early 60s, who had diabetes, and this was obviously poorly treated or not treated, and presented to me 3 months post-injury. And you can see she's almost dislocated her talus, and she has a malunion, non-union of her fibula. So we elected to go lateral. In this case, I certainly wanted to use a plate over screw fixation given her size and also history of neuropathy. We made an osteotomy at the level of the fibula malunion. You can see here with the microsagittal saw. And we've removed the distal fibula. And here's an example of that Henneman distractor, which really, really works well for visualization and also for soft tissue distraction. And we morselize the fibula, which you can see on the picture on the right, and just use that for local autograft. And we've reduced the ankle after preparing the joint. And in this case, if I'm using a lateral plate, I will do the home run screw from medial to lateral, so it's just opposite of the plate fixation. So you can see on this X-ray here, we place a guide pin just above the medial malleolus into the talus. And after we place the so-called home run screw medially, the plate is applied laterally. And in this case, we use a combination of locking and non-locking screws. And most plate systems now have a compression slot, as you can see here. So we were able to achieve excellent compression medially and laterally. And so here are the final X-ray images with the lateral plate fixation. But I would say about 90% of cases is the anterior plate, and certainly a minority would be using this lateral plate fixation. There are the final X-rays there. So many cases can certainly be treated with the cross screw fixation. For the reasons I mentioned, I think there has been an evolution to anterior approach and plate fixation. One, it's more stable. I think it's more reliable. You get better compression and leaves open the opportunity for takedown later. So that concludes my talk on the anterior approach to ankle fusion.